Okay, let's start. Good evening, everybody. I'm very proud to be here, to be invited. Thank you, the president of All India Ophthalmology Society and the president of the Scientific Committee of All India Ophthalmology Society for this moment, the privilege to talk with the distinguished people. I have no disclosure concerning this talk. I'd like to say some word for my friend, Nataranjan, Professor Nataranjan. We met something like 5 years ago. We worked along together at the board of RWC. He's a strong voice across the globe, advocating better scientific knowledge, scientific spreading education across all the world, and try to all understand how important is the vision, how important is to take care properly of all patients. Last year, he was here in Brazil. He was the key speaker for our national ophthalmology meeting, and he is doing a very good job. I would like to congratulate this great man. He was a great ambassador of India, and I can tell Natranca is very welcome in Brazil, and all ophthalmologists too, to come here anytime and cooperate and partner with many things we can do together. Let's start. Diabetics is a pandemic too. That's a huge number of diabetic patients, and India is one of the most popular diabetic in the world. And Brazil has more than 15 million diabetic patients that was not well controlled. The blood sugar and hypertension is something that we should keep controlled, but in the poor population, Brazil is not easy. And we have a very bad case that we should take care and try to prevent the loss of vision. And diabetic is a vascular disease that's gonna damage all the endothelial cell, the tight junctions, and this gonna leak fluid outside the vessel and cause edema. This edema and the other complication of diabetes, nowadays we have many tools to help patients like laser, injections, and vitrectomy. And we'd like to start the first thing that's big complication. Around 4% of all diabetic has macular edema that can prevent vision. And in Brazil, we have this PET survey, our Vitreoretina Society, a couple of years ago. And the majority of the doctors start primarily using injections for macular edema. After 3 or 4 injections, they are switched for steroids, mostly with Ozurdex. But what's the best drug to use to manage with the macular edema? The protocol T address these questions, and they shown us that the 3 drugs work well, but if you have 25th or worse vision, the best drug is aflibercept. But if you have 20/40 or better vision, any one of these drugs work properly. And another thing that have to address is when to switch drugs. And for these questions, we have this post-analysis for Neil Bracelet from US that was published last 2 years ago at the archives. And he shown us that it's very hard to predict with only 3 injections who's gonna be in 2 years very good vision or not. They say that with 3 injections, even the person has less than 5 letters gain can get good vision in 2 years. More than 40% of the group of the persons that has less than 5 letters gain in the first 3 months injections got better. In Brazil, used to do 6 injections and switch mostly for steroids. Another question that we have to address is, how do you should treat the proliferative diabetes, with laser or injection? And for this matter, we have the Protocol S. The Protocol S just published 2 years ago, the 5 years follow-up. And what they shown us with 5 years, doesn't matter if you use Lucentis or laser, the patient's gonna have the same vision after 5 years. And what the vision impairment with macular edema? The ranibizumab group has better vision, less macular edema, but was not so large the difference between the laser and the injection group. And concerning the retina detachment, yes, the group of injections has much less retina detachment at 5 years than the laser group. But the big question is, what happened with the people that lost to follow-up? And this group from Will's Eyes tried to get all the lost follow-up from the Protocol S and answer this question. And what you see, 20% of the patients lost the follow-up. And this 20% that lost follow-up, the person that was treated with laser has better outcome. And the patient that was treated of injection and lost follow-up has the worst vision, more retinal detachment, more neovascularization of the disc, and more neovascularization of the iris. And the other great question about macular edema is, when to operate this patient, what you should do. And you used to follow the work, the scientific, and macular edema is only with traction we should address surgery, or persistent, that one that you use injections and that you use steroid and keep very bad edema. And this case, we think some vitrectomy. And why some patients does improve the anatomically, but do not improve vision? Just because we have to look on not only the thickness of the retina. I mean, we need to see more details we call biomarkers. And a couple of years ago, they published a very good biomarker that we call DRILL. There's organization of the retina inner layer. What does it mean? The patient we can't distinguish the normal layers of the inner retina, even with the improvement of the macular edema, we still have very bad vision gain. Here, a patient of mine that has a very good result after a couple of injections, but very bad improvement in vision gain. Just because we can see in the app, we don't see any retinal layer, and after finish to have the atrophy of the macula. And we have, on top of that, we have not only the drill, but we have another biomarkers that we should look very carefully, like the external lines, like internal limitant line, external limitant line, and ellipsoid line. These two lines is very important. If they are broken, they disappear, probably the patient will not gain a lot of vision, even with the improvement of the macular thickness. And now we'll just go ahead and see what the improvement and the assessment of the patient. The wide angular angiography helped us a lot to see the non-perfusion of the periphery of the retina. And some work are correlating the periphery, the ischemia in periphery, and the macular edema. And this helped us to see better and treat this patient as better as we can. Another tool that is in the burst, but it's gonna help us a lot, is the OCT angiography. They can tell us very beginning of the pathology of the vascular in diabetes. They don't show us leakage just because they try to see the vessels by the movement of the cells. But we can see very well all layers of the capillary, the superficial and the deep capillary. This is gonna help us a lot. And this one in my right is something that's really matter in developed countries. It's the handheld retinography. This device can help us screening a lot of patients with all the health professionals that help us and send image for telemedicine, for artificial medicine. And with this device, we can screen a huge number of patients and help a huge number of survivors. Now I'll just talk about surgery. Something that's improved a lot since the beginning, the 70s, is the vitrectomy. We have the better tools, better machines, and the better visual system, like the 3D system. We have drugs, we have many things that's improved us a lot, the way to treat these patients. Usually we try to operate as soon as the patients comes to us, because we're gonna have much better results. This challenging case, like we shown in my left, that use bimanual and delaminate with the cutter, the small gauge cutter, is something that it's a lot of effort, but the vision gains is very low. And usually we prefer to use gas for all these patients. And now just to a little picture of the problem of diabetics in Brazil. In Brazil, we have more than 200 million of people, and only 1/4 of these Brazilians can afford with private health insurance. But all Brazilian has the right by the Constitution to the public system that has more around 211 million that use the system. But the system can't afford for everybody with the injections, vitrectomies, and for this, we should prevent bad case. That's gonna be cost less. And this, the Brazilian Council of Ophthalmology, he's the leader to try to produce a lot of material for educate diabetic persons. And in November, the month of the World Diabetic Day, during the whole month, they coordinate a huge screening project. And many doctors all around Brazil, they are volunteers, not only doctors, but also all health professionals. Last year, we gathered more than 2,000 people helping us, and we screening more than 100,000 patients that saved their lives, diabetic patients. In just a few minutes to end my talk, I would like to say all the health professional, doctor, nurse that are fighting against the COVID, that I have the profound respect. And I have to say, we are together gonna win this fight against this viral. And now I'd like to show you a beautiful picture of my city. The Salvador is from northeast of Brazil, is by the sea, is the fourth city of Brazil. And I hope in the near future, many of you can come here to visit me after this pandemic. Thank you very much to allow me the privilege to be here with you. Thank you all.
Thank you, Dr. Rocha, for this excellent talk. You see, I haven't had a lecture such brief but conveying everything. In fewest possible slides, very few slides, you covered everything in diabetes, from starting from protocol T to S to surgery, and showed videos also public health problem, screening, and also emphasized about this handheld cameras. So it's open to discussion, and the discussions will be done by Dr. Giridhar and Dr. Natarajan.
Okay.
George, for the wonderful talk. And as the talk goes, and most of the people who are viewing today are anti-segment surgeon. So if you have the diabetic macular edema or attraction detachment with the cataract, what's your approach?
I usually try to operate at the same time, because with cataract, the cataract prevent us to see well the back of the eye. And then we can't do vitrectomy well. We can't see of the no perfusion area to be treated. And it's very important, all this patient that has combined disease, cataract and diabetic retinopathy, they should have to go first to cataract, and or simultaneously to have the cataract and injections of vitrectomy as they need.
You see, this will be covered by one of the speakers also. Giri, any comment on?
I wanted to, ask him a few questions. Very nice talk, Professor. And thank you, Nati, for having invited him. I had, there is a lot of similarities between India and Brazil. We are both developing countries. And I was interested in knowing what is the practice pattern in Brazil. Do you use bevacizumab?
No.
In your bevacizumab, that is Avastin. Do you use Avastin?
Yes, we use a lot of Avastin here, mostly in the
Avastin in Brazil for the treatment of diabetic macular edema. Number two is, I was also interested to know whether a pan-retinal photocoagulation is the standard of care for PDR or other doctors who are using anti-VEGF in the management of primary management of proliferative diabetic retinopathy.
Yes, in Brazil, for the proliferative diabetic retinopathy, we use laser photocoagulation. We have no money to inject in this patient. It's very hard to follow these patients. The most of these people were not well educated and understand the high necessity to see doctors very frequently. And in Brazil, the system do not afford to injection for proliferative diabetics. And macular edema in the public system use mostly Avastin, but in the private health system, they can afford aflibercept or Lucentis.
Do you have compounding facilities for bevacizumab, Avastin in the Brazil?
Yeah, we have compounding pharmacies that help you to split the dose and help us to do this. And then we use many Avastin here, but photocoagulation is the primary approach for all Brazilians nowadays. We don't forget the laser because it's very important. As I show you with the protocol C, 5 years. Doesn't matter if you're injecting or do laser, after 5 years, the vision gonna be quite the same. But does matter if the patients lost the follow-up. When you lost the follow-up, the people will come you with very bad neovascularization, iris neovascularization, retinal neovascularization, and all kind of bad things that can happen in diabetics.
Yeah, okay. Even in India, actually, PRP, PRP is the primary form of treatment. I don't think that, in India, anyone is giving anti-VEGF as a primary mode of treatment. And the last comment I wanted to make, Lalit, is that I think we can work together.
Yes.
Brazil and India can work together. Nati?
Yes,
for
definitely.
sure.
Yeah.
I think it's going to be very good to partner with India. We are very close societies in the same way of development. And the large number of people. We're not like you that have more than 1 billion, but we have 200 millions and growing, and we have many problems, social problems, health problems, and I do believe that India has a lot to help us, and Brazil may help you too.
Thank you, Giri, for bringing in this laser, because I was, once I was hearing talk of Dr. Rocha, I thought he is deliberately, underplaying laser, because none of these slides showed laser actually. And I'm happy that Giri brought out this point. As in Brazil, so in India also. You see, PDR, still standard of care is laser. A very good laser done, and we have a follow-up for more than decades, 3 decades, patient doing very well. You see, affordability is an issue here also. And only indication of using anti-VEGF drugs in PDR would be when you have maximally done the laser and still patient has some ooze, or the front is in a very sensitive area despite laser persisting in the posterior pole. Then only we do. Thank Giri for bringing this out very, very nicely, and thank you, George, for briefly summarizing the entire DR management for the benefit of the Indian audience.